Good morning, good afternoon, good evening, everyone. It's Tuesday, it's Neurology Morning Report. Excited to see everyone here. And you know the routine. We would love to have someone present a case if they brought one, and two discussants to discuss that case with me. Ideally, one identifying as a woman and one identifying as a man. Do we have any volunteers? So the next 2 weeks I'll be on service. There will be no neurology morning report, at least not in this format. I'll be seeing neurology all-day reports. So all the more incentive to get some neurology in today before we take a break until the end of the month. Did anyone bring a case they wanted to present? Tough crowd. Okay. We do have a case. So we had one in reserve just in case. So we just need 2 volunteers then. One person to, or two people to discuss the case. Who would like to discuss today? Gabby's telling us it will be amazing. We already know that. Gabby always brings amazing cases for us to discuss. Who would like to discuss that case with Gabby and myself? You might be thinking, I have neurophobia. I don't want to talk about neurology. I have neurophobia. That's all the more reason to participate in this fun and safe space to discuss some neurology in a low or no pressure environment. Or you might be thinking, English isn't my first language. I don't know, discussing in front of 30 people. That's okay. We have Spanish speakers and Portuguese speakers and French speakers and probably speakers of many other languages as well. If you aren't sure how to say something, we'll just translate it. This is our routine here. Anyone? We can't get started without discussants. Who would like to discuss? Maybe you're thinking, I've never discussed before. Well, maybe today could be the first time. Maybe you're thinking, I have discussed a neurology case before. I want to make sure everyone gets an opportunity. That would be a reason to join as well. We have encouragement from Valeria, from Maria. Anyone? Gabby, do you want to introduce yourself and say some motivational words to get people to join us? Oh, we have one volunteer. Okay, Hans, sorry, I missed in all the, great. So Gabby, Hans, why don't you introduce yourselves? And then we just need the third side of the triangle to complete our lineup for this morning.
I guess I'll go first. My name is Gabriela. I'm from Brazil. I am a neurologist here. I work in my private practice as a general neurologist. I brought a case today for you that I saw during my residency. I hope you enjoy seeing it and we can learn together. It's going to be super fun and we need one more volunteer.
How can anyone resist? And yet 28 people are resisting. Okay, go ahead, Hans, introduce yourself. And then somebody is going to, who's just waiting, they're not sure. They're thinking this seems like a good idea, but I'm not sure. They're about to become sure, Hans. Help them become sure.
Yes, I'm a recent graduate at Ross University and I'm presently participating in the match. So hopefully something works out. And at the moment I'm visiting my mom and I'm at the oncology ward here in the University of Tübingen as a guest. So I can see patients, it's important.
Great. Thank you, Hans. Anyone like to join us? Valeria, fantastic. There are people who really want to discuss from the beginning and are just giving other people a chance to discuss. Valeria and Hans are both veteran discussants here. Happy to have them. Anyone, just last chance, you were thinking I was about to, and then Valeria said, okay, 27 of you off the hook until 2 weeks from now. Go ahead, introduce yourself, Valeria. Fantastic to have you again, and we'll go ahead and get started.
Thank you, Aaron. Yeah, I'm Vale. I'm from Lima, Peru. I'm a medical student. I'm really excited to discuss neurology today. Gabby's cases are always amazing.
All right. See all the excitement that you could join in 2 weeks? Okay. Fantastic. Gabby, go ahead and give us the chief concern, chief complaint, and we'll go ahead and get started.
Awesome. So the chief concern for today's case is seizure.
Seizure. Okay, Hans, you're going through the match. That means in a few months, you're going to be holding a pager and all sorts of things are going to come onto it, asking your immediate attention. And if you hear seizure, what would be the first thing starting to come through your mind?
Now, the first things that come to my mind are metabolic disturbances like low sodium, maybe even low glucose, the possibility for a space occupying growth like a tumor in the brain, but that we need to find out through our time course and whether it's the first time and whether and so on. And so metabolic growth, then possibly maybe an infection that could cause a seizure. Maybe the patient has a fever and meningitis or encephalitis, but I think less so in encephalitis. Those are the three things that come to my mind right away with a seizure.
Excellent. So yeah, long list of things on the differential diagnosis for a seizure. If we've decided that this is certainly a seizure, as we'll learn soon, and those can include metabolic disturbances. Hans gave us a few, but the list is very long: hyponatremia, hypoglycemia, hyperglycemia, hypomagnesemia, hypocalcemia, mostly the hypos for some reason, usually not potassium, that does muscle stuff. So space occupying lesions. Does this patient have a brain tumor, or that's primary or metastatic? Does this patient have a primary infection of the nervous system, meningitis, encephalitis? Does this patient have a toxic ingestion, medication? All great thoughts, Hans, to start thinking about elements that could be causing seizure. What's running through your mind, Valera? And then I'll talk a little bit about my approach to seizure.
Yeah, I think the first thing that I would ask if it's the description of the seizure, to see if it's a seizure or maybe syncope, to ask if the patient had a positional state, or maybe we find him or her in a positional state. And also if there was, for example, release of sphincters that makes seizure most likely rather than syncope. And the pattern, if it's generalized, we will expect maybe loss of consciousness, and to see what the pattern of movements was, if it was an absent seizure or motor seizure, and if it was partial, what part of the body it compromised, to maybe see a localization, and also ask if it's a first-time seizure or not. That I think could change the management, because I think if it's a first-time seizure, we would ask for an EEG and maybe some imaging to see if there's like a specific cause, like a stroke or a focalized infection or lesion that could explain the pattern. So yeah, that's kind of what I'm thinking.
Fantastic. So I love that you backed up a little bit here, as we must always do, and ask, is this really a seizure, right? So when I hear seizure, that's my first question. I have a couple of questions. And the first, was this really a seizure? Because some people will describe an event as a seizure and it may appear to be a seizure, but it could be something else. So syncope is an example. If what actually happened, as you said, Blair, we're going to ask, well, okay, you said there was a seizure. What actually happened? Did the patient lose consciousness? Because you could lose consciousness from syncope. Was there some shaking and jerking? There can be some shaking and jerking from syncope, right? Because there's not enough blood going to the brain. And I've probably told this story a million times, but the whole point of syncope is to lie down, right? There's not enough blood going to the brain. The body has a reflex to get you lying down so the heart doesn't have to pump against gravity. If a patient has syncope and can't lie down, and they are stuck, they're in a seatbelt or something in a car or something like that, they might have a seizure from hypoxia, from whatever is causing them to need to have syncope. I had a patient who I followed and debated with the epileptologist. The epileptologist thought it was seizure. I disagreed. It was a guy who kept having when he had his seizure, his event, it was when he was playing poker with his friends, and he would turn pale, turn blue, and slump over, and then he would start shaking and jerking. And I thought, these keep happening in the same place, and the whole beginning of it sounds like syncope, but he can't get down because he's in the chair and his friends are trying to help him. And the epileptologist he saw put him on anti-epileptics, and I kept ordering him for more and more cardiac monitoring, and finally found that these were an arrhythmia, actually. So Valeria, the first question, you're right, was this a seizure or was it syncope? That's the main differential diagnosis. You talked about different types of seizures. One of the other differential diagnoses for epileptic seizure is non-epileptic seizure, or psychogenic non-epileptic spell or seizure, where the patient is having some type of psychogenic episode that can look like a seizure, but is not an epileptic seizure, just still a real medical condition under the category of functional neurologic disorder, but is not from epileptic activity in the brain. Some people will say in the differential is TIA. TIA shouldn't cause loss of consciousness and usually going to cause negative symptoms, meaning the patient is weak, or the patient can't see on one side, or the patient can't speak. But seizures can do anything, and depends where the electrical activity in the brain is, right? And if it spreads to language areas, the patient can be aphasic because the language areas aren't working, and it can look like a stroke or a TIA. So first question is, was this a seizure? If it was a seizure, and the next question that I would think about is whether it was provoked or unprovoked. And Hans got at this a little bit. So what do we mean by provoked and unprovoked here? Provoked has a very particular meaning, and that's that the seizure was caused by something that was acute and reversible. I say that because you're going to see there's a few ways this is applied that don't make sense if you just think of provoked in the colloquial sense. Acute and reversible. So patient has an electrolyte abnormality, normal brain, but bad humors, right? Too much glucose, not enough sodium, whatever it is, brain has a seizure. Patient has malaria and their fever gets really high, even without cerebral malaria, they can have a seizure. The brain doesn't like being at 105 degrees, right? So these are called provoked seizures, meaning there's an acute provoking factor that's reversible. Patient takes a medication that has seizure as a side effect, or takes a drug, or is withdrawing from alcohol, etc. Provoke, 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 provoked. Okay, the brain is healthy, brain is normal, but there's some provoked etiology. Meningitis, encephalitis, you might say, oh, the brain's not really normal in those, but that's acute and it should be reversible, right? The patient may have seizures from that, but we should be able to fix it with antibiotics. When is it unprovoked? Well, you might say, oh, those must be the people who are born with epilepsy, genetic epilepsies. Right, that's right. Those are unprovoked seizures, right? The brain has some abnormality, either some structural or electrophysiological abnormality that provokes a seizure in the colloquial sense, but these are unprovoked, meaning there's no acute reversible factor, right? What about a brain tumor? Hans mentioned. What if the patient has a brain tumor? Provoked or unprovoked? Well, you might say it's provoked by the brain tumor. Yes, colloquially, yes, but this is unprovoked. Why is it unprovoked? Because the patient didn't develop the brain tumor acutely, and it's not reversible, right? So the patient develops a brain tumor. Why did they have a seizure on Tuesday and not on Monday? Unprovoked, right? Something random happened related to that tumor. So if there's a structural lesion of the brain that's not acute and not reversible, that's unprovoked. And why are we making such a big deal out of this? Well, if a seizure is provoked by an acute reversible factor and you fix that, the patient doesn't need anti-seizure medicines. Used to be called anti-epileptic drugs, now more accurately called anti-seizure medicines. Doesn't need those for life, right? Because you fixed the problem. Their sodium was low, you fixed it. They had meningitis. Now, some of these get messy, right? Meningitis and encephalitis can predispose a patient to seizures later. So during the acute event, they had a seizure, it was provoked, treat the meningitis. 2 years later, from that focal area that's damaged from encephalitis, they have seizures. Now they're unprovoked. Why? They had a prior infection that's not acute and not reversible, right? So one of the most common causes of epilepsy in adults is prior stroke. Prior stroke. Yeah, because that causes a scar in the brain, just like a MI causes a scar in the heart and predisposes to arrhythmia. So if a patient has a seizure at the time of their stroke, it's provoked, right? If the patient has a seizure 2 years after their stroke, it's unprovoked. So some of these get a little confusing. So remember, provoked is acute reversible. And if you do your workup and you find no electrolyte abnormalities and no meningitis, no encephalitis, no acute structural abnormalities, right? then you're worried that this could be an unprovoked seizure, and the patient is at high risk for recurrence. And that risk, as Valeria said, could be quantified to some extent using EEG and some other measures that we'll talk about if that becomes relevant. So those are really the big things. And then you both mentioned, helpfully, is this the first seizure, right? So a patient might have a first seizure, and then we're really doing this mega workup, right? Or is this a patient with known epilepsy who's had a seizure? And then we still have to look, well, why did they have a seizure today and not yesterday? Did they miss their medicine? Did they run out of their medicine? Did they take a new medicine that interacted with the old medicine? Do they have an electrolyte abnormality or an infection or something that's causing a patient with unprovoked seizures, epilepsy, to have an acute provoked seizure, right? So was it really a seizure? We're going to find out more on the history, and we'll talk about what features might help. And then was it provoked or unprovoked? We might get some information on that on the history also. So those are my first two key questions when I hear seizure. And both of you together put most of this information on the table, but I wanted to add that conceptual framework of provoked versus unprovoked. All right, Gabby, let's hear some history.
Yeah, awesome discussion as always. So regarding the HPI, it's a 23-year-old female that presents to the emergency department with a new onset of the following symptoms. She suddenly starts to stare and stops what she's doing. This was interpreted as behavioral arrest, followed by deviation of the eye. They don't know to which side the eyes were deviated to, and tonic movements of the whole body with a duration of less than 5 minutes. They think it's about 2 to 3 minutes. And she loses her consciousness during the episodes. She had 3 episodes like this, and they were followed by confusion, somnolence, and noisy and profound breathing for about 3 hours, and then she recovered her consciousness. She did not urinate involuntarily during the episodes. She didn't have any tongue biting or major traumas. And she started to have these episodes one day before, and today she called the ambulance, where she was given IV diazepam after the last seizures 3 hours before the presentation. She didn't have any previous episodes of seizures. Previous medical history: she has sickle cell disease. She is on a regimen of blood transfusion every 2 weeks. She had a cholecystectomy previously. She had a patent ductus arteriosus that was successfully operated when she was 8. And she had more than 20 previous hospitalizations due to sickle cell anemia complications, pain crisis, and acute chest syndrome. She denies febrile seizure during infancy. For medications, she uses folic acid 5 milligrams per day, aspirin 100 milligrams per day, hydroxyurea 500 milligrams per day, and gabapentin 400 milligrams twice daily. Family history: she doesn't have any relatives with epilepsy. Her sister has sickle cell anemia and had a stroke when she was 4 years old. And for social history and allergies, none.
No, very good. Okay, thank you. Wow, lots of information here. Let's first ask a simple question to both of you. Hans, was this a seizure?
Yes, I would say so, because she, at first it looked like an absent seizure, but it's not. It's almost, I hope I'm correct here, a complex seizure, because she lost consciousness, and she had a post-ictal phase, even though she did not urinate, but it's the entirety defines a seizure.
Yeah, excellent. I agree. So right. So often we don't see the seizure, right? And even in I'm a neurologist, right? And I've been doing this for a while. Gabby can probably agree. You get a page for seizure. By the time you get to the bedside, it's over, right? Most seizures are very brief unless the patient's in status epilepticus. So we're mostly just relying on the eyewitness to tell us, or now in the modern age, some people take a cell phone video, which is very helpful. So what are some of the things we can use here? Hans told us, right? There's tonic-clonic movements. So not all seizures have that. There are myoclonic seizures and atonic seizures and absence seizures, as Hans mentioned, but we have those. We have a loss of consciousness. And we have a post-ictal state, right, where the patient's confused, sleepy, breathing heavily afterwards before they come back to normal. Shouldn't really have that with syncope. Now, everything has a caveat, right? Syncope, patient usually wakes right up. As soon as they get horizontal, right, they wake up. What if they have syncope and hit their head on the stove in the kitchen on the way down and have head trauma? Then maybe they'll have a concussion and they might have what looks like a post-ictal state, but nothing to do with seizure, right? So all of these little features here, Hans mentioned she didn't have urinary incontinence. Urinary incontinence can occur during a generalized seizure. But what if someone gets up to go to the bathroom at night and they pass out? They get up too fast and they have orthostatic hypotension. And then they pee because they lost consciousness and stopped consciously controlling their bladder. So none of these things are perfect, right? All the things we learn in the textbook, seizure versus syncope, are helpful, but none are perfect. And even seeing the event, one of my mentors, and some of you know from Twitter and some of her webinars, Tracy Milligan, would show these videos of patients and ask whole audience at a conference, was it a seizure or not? A whole audience of neurologists couldn't even agree, even seeing the event. There's these frontal seizures where the patient will do somersaults. It really doesn't look like an epileptic seizure, and it is. There's post-ictal spitting and post-ictal nose wiping and ictal laughing and all these things that can happen depending on where called gelastic seizures, where the patient is laughing, and it's from a hypothalamic hamartoma usually. So you can see anything and you can get confused, but this sounds pretty good, probably, right? As good as we're going to get. As Hans said, the patient has some type of altered consciousness, and then that seizure activity is clearly affecting both hemispheres. They're not maintaining consciousness, and then spreads to the motor regions. They have tonic-clonic activity, and there's a post-ictal state. So tongue bite would have helped you. Urinary incontinence would have helped you, but without them, we can still call this a seizure. And sounds like a generalized tonic-clonic seizure. You mentioned absence seizures, Hans. These really only occur in childhood epilepsy syndromes. For an adult to have new onset absence seizures would be very atypical. Usually if an adult has them, it's from childhood. And you use the term complex partial. For some reason, every 5 years, the epileptologists change all the names around. So there used to be something called simple partial, which means a focal seizure and the patient doesn't lose consciousness, and complex partial, that's a focal seizure with impaired consciousness, but they don't use those terms anymore. Now they call it focal seizure with preserved consciousness or focal seizure with altered consciousness or something like this. Maybe they've changed it again since I last looked. Epileptologists like to change the names of things. Okay, so this was a seizure. And so Hans, I agree with you. And Valeria, I was going to ask you, to say, but go ahead. What were you going to say?
I wanted to ask you about, you were talking about how to differentiate seizure from syncope. And I remember a professor once saying that there were like laboratory markers that you could use, like I believe phosphate or something like that. I don't remember exactly, but I wanted to know your opinion on that.
Oh, the serological markers. Is it prolactin? I'm saying it and now I'm doubting it. Is that right? Yeah. Because you can see I've never sent it. Yeah, there's some data to suggest that if you've had an epileptic seizure, you spill a little, is it prolactin? Am I right? I'm saying it and now it sounds funny. Yeah, Maria, what does this mean? That's yes? That's you nodding your head yes with your finger. Okay, very good. Thank you. I'll learn they're helping me. It's like the fake hypnotism shows, right? Where someone's actually giving you the answer from the back row and you look like you know everything. Prolactin should go up after a seizure, but I think it can also go up after syncope, and it shouldn't go up after a non-epileptic seizure, but I think you have to get it within a certain time window, and then by the time it comes back, and my understanding, where I trained, we never sent it, and the epileptologist said it's not helpful, but I haven't looked at the data in detail, true, but not necessarily helpful in practice. What I was going to ask you, Valeria, is what else do you want to do with this history? So I think we all agree that patient sure sounds like they had a seizure. What other thoughts do you have as regards to some of our other questions here?
I think the onset of the seizures, which is acute, and the fact that she has had multiple seizures in a short period of time, and the past medical history makes me think about something like sudden or acute, like probably something vascular. The past medical history of sickle cell disease also makes the possibility of an ischemic stroke more likely. I'm not sure if aspirin is really effective when you have the sickle cell anemia. I remember that patients did like blood transfusions to prevent strokes. And so I'm not sure if she hadn't been receiving blood transfusions, then she was at an increased risk, even though she was receiving aspirin. And yeah, I think that an imaging would probably be my next step.
Yeah, great. So right, just taking the HPI alone, this patient has had 3 seizures here recently after never having seizures before, not having a history of epilepsy. This is very concerning for some provoking factor. And again, whether that's provoked in the sense some acute reversible factor or provoked lowercase p, provoked, right, that there's some tumor or some other lesion there that's not acute, not reversible, but provoking the seizure, though it would be considered unprovoked. Yeah, so what to do with, when I agree with you, you hear sickle cell disease and you try to make a Venn diagram with neurology, the main thing you would think of would be stroke. I forget the numbers, but untreated, something like 10% by age 20 patients with sickle cell will have a stroke. Someone can correct me. I don't know the exact numbers, but I remember looking it up at one point, and it's quite high, actually. And I also remember reading, though someone can correct me, I'm not a pediatric neurologist, that you would think it's because the cells are sickling in the cerebral blood vessels and causing occlusion, but I think it's actually the sickled blood vessels are doing damage to the large vessels and causing stenosis over time, and can also cause moya disease, which we'll get into if it's relevant, because that's a whole other discussion. But right, sickle cell disease, cardiac disease, we should be thinking about stroke. So then the question is, what's the relationship, if any, between stroke and seizure? When a patient has a stroke, we're really talking about 2 potential underlying conditions: ischemic stroke and intracerebral hemorrhage, right? Sometimes called ischemic stroke and hemorrhagic stroke, both presenting with acute onset focal neurologic deficits, one due to ischemia, one due to hemorrhage. Seizure at the presentation of intracerebral hemorrhage is not uncommon. I don't have an exact number for you, but there's blood in the brain, and that's irritating to the brain, and so the brain seizes. Ischemic stroke seizures are actually pretty uncommon at presentation, something like 1 to 2%, but even that number sounds a little high to me for the number of times I've seen that presentation in many, many years. So did the patient have a stroke? But we didn't hear about a stroke syndrome here, but maybe a stroke of some area that's a little bit in what we would call not eloquent cortex, right? It's seizure somewhere in a temporal lobe on one side, and there's no obvious clinical deficit, but it's created a little nidus for seizures. Or what we always have to ask is, do we have to put aside all that past medical history? And yes, she has sickle cell, and yes, she has congenital heart disease, but that has nothing to do with the fact that she's having seizures now, and she has a completely other disease process going on in the brain. But I agree with you, Valeria, if we were going to make a relationship here between the past medical history and seizure, it would probably be through some vascular mechanism. I'm not aware, though, if we have any pediatricians here, maybe could tell me, or someone who did their pediatrics rotation recently. There's an increased risk of seizure in patients with sickle cell disease, not to my knowledge, without the mediating factor of some vascular lesion. Okay, so what are we going to be looking for on the exam, if anything? Valeria says we need a scan. I agree. I mean, we're going to need a scan, whatever. If the patient's awake and not seizing anymore, that's great. She gets a scan. If she's still seizing, then we have a lot of other homework to do to treat status epilepticus. We can talk about that, but also in parallel would need a scan and a workup. So anything in particular, Hans or Valeria, that you're looking for on the exam?
maybe if she's in a post-ictal state, or would you call this status epilepticus just because she has had so many seizures in 24 hours? Or
Would we call this status epilepticus? So what's the definition of status epilepticus? Do we know?
yeah, I think it is a seizure lasting more than 5 minutes, or I think 2 in 24 hours, if I'm not mistaken.
Yeah, so I think the old definition was seizures lasting more than 30 minutes, but if you're sitting there watching your watch, letting a patient seize for 30 minutes, the patient is not going to do too well. So the new definition, unless there's another new one, but the newest definition I'm aware of is point 1 was correct, Valeria, which is seizure lasting more than 5 minutes. Point 2 is more than one seizure without return to consciousness between. So it takes the time piece out of there. And the idea here is that once a patient has been seizing for more than 5 minutes, if you don't treat it, the seizure is sort of a self-perpetuating electrical thing going on in the brain, and it's going to get even harder to treat. So seizing for more than 5 minutes or multiple seizures without return to consciousness between them, right? So we didn't, here it sounds like there's been 3 seizures. Presumably the patient has woken up between them, or they would have come to the hospital sooner. But right, we're going to want to see on the exam, is the patient back to baseline or not? Yeah. Anything else on the exam?
I think also the eyes, probably, if the eyes are maybe deviated to one side, that could locate a possible stroke, if that's what we are thinking, just because of the past medical history.
Yeah, so the eyes are going to be a little bit tricky here, but I agree with your larger question. Is there anything focal, kind of residual here? So you've probably all heard of Todd's paralysis, right? I don't know who Todd was, but Todd's paralysis, that a patient has a seizure, and if that seizure has a focal origin, then that area that's been seizing goes into some refractory state, and the patient might have, say it was in the left motor cortex, might have a right hemiparesis after that. I've seen patients actually that come into the emergency room triaged for stroke. They look like they've had a stroke, and while they're going for their CAT scan, start having a seizure, and then the scan shows they have a brain tumor or something like that, and we realize, oh, they had a seizure that was unwitnessed, fell out of bed or fell off the couch, and when the person found them, the seizure was over, and found them with a Todd's paralysis and eye deviation. And it looks to everyone, including the neurologist, like they had a stroke. So in the differential diagnosis for stroke is, did this patient have a seizure and a post-ictal state is what we're actually seeing. And if you can see a hint of focality on the exam, that might tell you, oh, maybe there is a focal lesion that led to what's called a focal seizure with secondary generalization, although they may have changed the name. I think actually they did change the name recently for that one too, but the principle remains. So that'll be helpful. The eyes are tricky, right? Should we go down this rabbit hole? What time is it? All I'll just say is that if the patient is actively seizing and the seizure activity gets to the frontal eye fields, the frontal eye field sends the eyes to the contralateral side. Makes sense, right? Left brain controls right body, sees right visual field. So left frontal eye field sends the eyes over to the right. If seizure activity goes to that area and gets it active, the eyes will be deviated to the right. The head might turn to the right, might be the beginning of the seizure. But in the post-ictal state, when that left frontal eye field is refractory, asleep, then the eyes might be looking over at the left. It looks like the patient had an ablative lesion or a stroke on that side. So certainly I agree with you. Eye deviation would be concerning. The question would be, does it represent ongoing seizure activity, a post-ictal state, or a stroke causing seizure? And it would be a little hard to say without knowing what else is going on. If the patient is still not conscious and not talking to us, the other important thing I'd be interested in on the exam is this a post-ictal state, or is the patient now in non-convulsive status epilepticus? So patients can have seizure activity that continues without actual observable symptoms in the body or obvious tonic-clonic movements. So little things, little continuous rhythmic twitches of the eyelids, or what looks like nystagmus, but is actually twitching of the eyes, or some little rhythmic twitches ongoing in one region to suggest, uh-oh, this patient isn't done seizing. They're not in their post-ictal state. They're actually in status epilepticus. So those are some things we'll want to see on the exam, or if the patient is fully back to normal and there's no subtle neurologic findings, then we'll focus on the workup. So what did you find on the exam here, Gabby?
Yeah, I know you had high expectations to this exam, but actually everything was normal, including the fundoscopy, all the neuro exams. So she was awake, she was oriented, and all the remaining of the exam was normal. And I'm gonna tell you the vitals as well. Temperature was normal, heart rate was 80, blood pressure was 12/9, 120/90. O2 saturation was 95%, respiratory rate was 14, and I don't have the exact value, but glucose level, finger stick glucose was also normal.
Great. Well, that's good. Yeah, we didn't want her to still be seizing or comatose, and that's why I didn't want to get too much into those details. So we spend time on what will be relevant to the case, or at least some time. This patient has a completely normal exam. Valeria, what would you do next here?
Okay, so I think a metabolic panel will be important just to rule out other metabolic disturbances like sodium and calcium. And also thinking as if this is a first-time seizure, to get an EEG and some imaging. Even though we don't have focalization here, it still could be something focal happening that just is presenting as a seizure. So I think that will be my next step.
Okay, and Hans, what would you add to this list? So Valeria wants some blood work, particularly focusing on electrolytes, and wants an EEG.
Yes, in that case, I would, if available, a CT head or preferably an MRI head, just to see whether there is any demyelination or anything else going on in the brain that could explain the seizure.
Excellent. So I agree. This patient needs a lab workup, right? Any electrolyte abnormalities? We've heard the glucose is okay. Any toxic, metabolic, toxic or drug? So a tox screen. We didn't hear anything on the history, but not, we maybe didn't ask, or sometimes you won't get the full answer the first time. So electrolytes, tox screen. Certainly head imaging, CT is going to be the quickest, right, and easiest to get to let us know if there's some catastrophic neurologic emergency. But I agree with you, Hans, MRI is going to give us more information, as it's can show more subtle pathology. And then EEG, electroencephalogram. So just to say quickly, this is sort of the EKG of the brain, but in some ways it's not the EKG of the brain. Why is it the EKG of the brain? Well, we're looking at the electrical activity in the brain with electrodes. Why is it not the EKG of the brain? Because the chest wall is pretty thin compared to the skull. So you are getting something that's a little less or a lot less precise than what you get on an EKG looking at the heart. In fact, if you see a patient on the EEG, sometimes those EEG leads will actually pick up the cardiac rhythm because it's more accessible to them than what's buried deep in the skull. And so EEG is very hard to interpret. Any internist, right, family doctor goes through residency, comes out able to interpret EKG. EEG, after neurology residency, you need a 2-year fellowship to learn how to interpret. It's very complicated. There's lots of artifacts that can look like seizures. There's lots of very subtle patterns. There's lots of complicated terminology for subtle things. And I think most times, correct me if I'm wrong, 2 doctors will look at an EKG and be able to come to consensus, but 2 doctors can look at an EEG and have totally different interpretations. So it's a helpful test, but it's not sort of a slam dunk test like getting an EKG. And the so-called routine EEG, where you just put the electrodes on for 20 minutes, record, and then you're done. What are you looking for? If the patient is back to normal and awake like this, you're looking for what are called interictal discharges, little signals that some part of the brain is not firing normally that could predispose to epilepsy. Well, guess what? EEG is only 50% sensitive for finding those. That's not very good. And if you do 2, you get to about 70%. And if you do 3 and sleep deprive the patient, you get maybe to about 90%. But and then patients that don't have epilepsy, about some small percentage will have some discharge that someone might call an epileptiform discharge, even though they'll never have a seizure in their life. So not the world's greatest test. The epileptologists don't like when I say that, but it can be when is it the most helpful? If this patient was still in a coma, we put the EEG on, then we know right away, is this patient seizing or postictal? Very helpful, right? This patient's having a spell that might be a seizure, it might be syncope, it might be psychogenic non-epileptic seizures, PNES. Then, yes, bring the patient to the hospital, put the leads on, and watch. And when they have an event, you get a direct readout of what's happening. And sometimes the EEG is normal and the EKG has a pause. Say, oh, this patient is having hypoxia from a cardiac arrhythmia, not seizure. Or the patient has a totally normal EEG during the event. You say, no, this is not an epileptic seizure. So those are the places it's very helpful to just sort of get it as a test, like the EKG doesn't prove that it was not seizure if it's normal, and doesn't necessarily prove that it is seizure if it's abnormal. So just to be aware of some caveats there. But I agree, we would get it. Why would we get it in this case? Well, if it's abnormal, that's going to be very helpful to us. And there's something called the MESS study. Well, do I want to go down that road? Let's just say if this patient had one unprovoked seizure, we do the whole workup, we don't find anything. An abnormal EEG would tell us that their risk of another seizure is high enough that you would treat them, right? And a normal EEG in someone who's had a single seizure that's unprovoked, you don't find anything, a normal EEG would reassure you that you may not need to necessarily commit them to lifelong treatment. There are studies we can get into if that's relevant. But okay, I agree. Let's get labs, imaging, and then EEG probably the least urgent, but we'll probably get it eventually unless we find an obvious etiology on the other tests. Gabby, will the next, so I can decide what questions to ask, will the next aliquot reveal the final diagnosis, or you have some steps for us?
Actually, I have a brain MRI to show you.
You have a
and
brain
some
MRI to
labs. So
Okay.
maybe I can tell the labs and.
Maybe one second. So let's just say this, we're about to see these studies. Do you, any sense of what we might find? Hans, what do you think? Will the MRI be normal? And if not, what are you looking for on the MRI?
First thing that I would look for is there anything like a tumor in the brain that might cause that would be a red flag? Then maybe, is there a demyelinating disease going on which destabilizes the neurons in the brain and the nerves? Yeah, those are the two things that I would be interested in an MRI. Okay,
sure. So brain tumor could present just like this. Patient is doing fine, and first symptom is a seizure, subacute or chronic disease presenting hyperacutely. Demyelination, so multiple sclerosis, sort of an acute flare causing a seizure, would be pretty uncommon. We call multiple sclerosis a white matter disease, though advanced imaging is showing it does have some gray matter effects, but usually an acute flare, there would be some focal deficit rather than seizure. There are acute demyelinating syndromes. We had a case recently of ADEM, or acute hemorrhagic necrotizing encephalitis, or one of those. Recently, there are these sort of fulminant demyelinating syndromes that can present with seizure. So yep, two possibilities. Valeria, what else might you be looking for here?
I feel totally guilty because actually Hans put it in the chat and just came to my mind that I have failed as a Peruvian medical student, because every time we see a patient, usually are males that present with new onset seizures, we obviously have to think about neurocystic psychosis as a possibility. So yeah, thank you, Hans, for reminding me of that.
Yeah, so infections, right? This is a pretty acute situation. Does this patient have meningitis with no fever and otherwise normal, no headache, no neck pain? Pretty unlikely. Does this patient have encephalitis? Possible. No fever for an infectious encephalitis, maybe a little less likely. No confusion, nothing else, maybe not yet. And then, of course, in endemic areas, 30% or so of epilepsy is due to neurocysticercosis, Very, very common infection and infectious cause of epilepsy. So yeah, we've had many cases that have ended as neurocysticercosis here, presenting with headache, presenting with hydrocephalus, presenting with seizures. So always on the differential. And of course, with global travel and migration, we see lots of neurocysticercosis in non-endemic areas also, So yeah, there could be infections that are not acute infections, like bacterial meningitis or viral encephalitis that could show up here. And neurocysticercosis would be one. If this patient has undiagnosed HIV, then we're also invoking toxoplasmosis and PML and primary CNS lymphoma and all sorts of other infections. Other things we might see on the scan that could have caused the seizure? Anything else?
Maybe the stroke that we're looking for, but we don't, I don't have any, oh, there's no focalization on the exam, so I really wouldn't know exactly where to look for it.
Yeah, good thought. Taking the past medical history into account, did this patient have some asymptomatic stroke at some point, right? That didn't cause symptoms or was a while ago and they forgot about it or didn't tell us and nothing obvious to show for it on the exam, but created a nidus for seizure. That's certainly possible. And then in the vascular family, cortical vein thrombosis, venous sinus thrombosis can also present with seizure. Often there's headache preceding it, but not always. I don't know if patients with sickle cell anemia are in any way predisposed to that, but just something to keep in mind. Can be a hard diagnosis to make if you're not thinking of it. That's the other thing I'd maybe put on there. Is this MRI going to be abnormal? It's hard to say in this case. I always like to try to guess before in real life also, because then not just in morning report. As Valeria said, there's nothing focal here on the exam, but the brain has lots of different places in it where things can hide without causing anything focal. But I'm not sure. I'm not sure. Usually I say I'm going to predict it, and then I say I'm not sure in a case like this, that all we have is seizure in a normal exam. But if we want to really put everything in the mix here and say it's something vascular related to the prior history, then maybe we would have to say maybe there's some either acute stroke and it's small enough that it didn't cause deficits but caused a seizure. That could be maybe somewhere in the temporal lobe, or the patient had a prior stroke and is not aware of it causing any symptoms, and that scar is the nidus for seizure. I guess that's possible. I don't know. I don't know what we're going to see. I don't think we're going to see some big electrolyte disturbance or other things like that. But okay, tell us what you actually saw, if you can, without telling us the diagnosis, so we can interpret the data.
Okay, so actually electrolytes were normal. Complete blood count, complete metabolic panel as well. HIV and syphilis were negative, and she only had anemia, but she previously had anemia, of course. We also have should I show you the MRI right now?
Sure.
Okay. Can you see it?
Not yet. Yes.
Yeah.
Okay.
So this is her MRI.
Don't tell us. Yeah. Anyone see anything there?
Ring enhancing lesion.
Yeah. Where is it?
I think it's in the frontal lobe.
Yeah.
Just next to the probably the central gyres.
Yeah. So
I think for ring enhancing lesions, I would say, so if it's very well demarcated, but it's a little thick. I mean, it's not super thick, but I think the fact that it is completely enhancing makes me think more about infectious and malignancy than demyelinating diseases that usually have like a C shape, incomplete enhancing. And the fact that it is, I mean, I'm not sure by this because infections are usually thin borders, not very, or very regular, not nodular, and malignancies are more nodular and irregular borders. So I think for this case, maybe thinking about an infectious cause. And I also know that ischemic strokes can present already in patients, but I think I know that it's way more rare. So infections would probably jump up my differential a lot.
Valeria, are you a secret neuroradiologist? You know so much neuroradiology. That is amazing. Yes, this is a T1 sagittal post-contrast image, and we saw a ring enhancing lesion here, very close to the, so we can't say if this is left or right side, but very close, clearly very superior, almost maybe in contact with the meninges, it looks like. And yeah, ring enhancement, very good. What could we think about their infectious lesions like abscess, neoplasm? And then you can get ring enhancement and demyelinating lesions, but good for you for knowing this. I probably learned this as a third-year neurology resident, but you can get open ring enhancement and demyelinating disease. You can also get ring enhancement, but if you see that open ring type of appearance, like a C shape, that can help you. As far as the thickness of the wall, I haven't looked at that literature and data. I've heard people say that. I'm not sure necessarily how helpful that is. I don't know if you have other sequences. Gabby, I'd be interested how much edema there is around this. Is this the only lesion? Can you tell us? One lesion?
Yeah, so this is an isolated lesion, and there is a surrounding vasogenic edema. I don't have the other sequences, sorry. I just have
no problem. So yeah, you can see on T1 a little bit of hypointensity around that as edema, but it would be probably more obvious on T2. Mm-hmm. Okay, can we make a diagnosis or do we need more tests?
Well, I think for memory enhancing, thinking about infectious etiologies, for example, a bacterial abscess would probably be less likely just because I would expect more edema surrounding it and fever. But also all the other ring-enhancing lesions could include neurocysticercosis, even though it's usually multiple lesions are smaller ones, but could also be only one. Also toxoplasmosis, even though it's usually more in the basal ganglia, I believe. And also possibility of a tuberculoma that I know can present similarly. And I learned recently that it can also be tuberculous abscess. That can also be a cancellation. And I don't know what you think about the location in terms of thinking about infectious etiologies versus others. Like if it's cortical, would you think, okay, this is not toxo, or what are your thoughts on that?
Yeah, amazing, Valeria. Amazing discussion. Right, so it's a ring enhancing lesion. It can be anything. And the location doesn't help us too much. You're right, toxo likes the basal ganglia, but can you get a very toxo lesion close to the cortical surface? Absolutely, you can. Shouldn't it be multifocal? Often it is. Can it be one? Yeah. Neurocysticercosis, it shouldn't. I don't know, it doesn't enhance. It's just a little circle with a dot. Yeah, you're right if it's the vesicular phase. I thought it was just a little calcification. Yeah, you're right if it's the calcified stage, but between those, there's the granular, colloidal, and granular nodular stages. I think I can never remember them, but they cause a ring enhancing lesion with edema around it. In my experience, those are usually little tiny rings. This one is a little bit bigger, but neurocysticercosis is fair game. Tuberculoma is fair game. You're right. Some people can distinguish tuberculoma from tuberculous abscess. Effectively, they're the same, but good for you. The pathology is a little bit different, though I couldn't tell you how. So I don't think the location helps too much. The only thing I'd caution in your reasoning, which was otherwise beautiful, was the lack of fever doesn't take us away from a bacterial abscess, because an abscess is walled off in the brain, right? So people miss this, where they'll say, it can't be an abscess, there's no fever. It can absolutely be an abscess still, brain or spine abscess. I don't know the percent, but a significant percentage have no fever, because this is walled off, unless it's ruptured into the meninges. So this is near the meninges, but if it's truly walled off, this patient could have no fever, could have a normal lumbar puncture, because all of this is just stuck in the parenchyma and the CSF is not infected. Other thoughts on what this could be, Hans? Oh, and let me just, you said a stroke could be ring enhancing. Good for you. You might say stroke ring enhancing? No, isn't a stroke. So in the subacute phase of stroke, it can be ring enhancing, not acutely, but somehow when the tissue is damaged, repairing itself, whatever, the blood-brain barrier is leaking, you get some enhancement there. And my experience is it can look ring enhancing, usually doesn't look as perfect as this one. And usually there's sort of signs that there's, rather than expansion, that there's actually some encephalomalacia around the enhancing lesion. So I have a very memorable case of someone who was diagnosed with a brain tumor and came for a second opinion. And my second opinion was that, congratulations, or good news, well, different news, good, you don't have a brain tumor, actually, it's a stroke. So it is on the differential, it's not really sort of in a stroke territory, which is the other thing that can help you with that. And it sort of has edema around it, so probably less likely stroke, but good for you for knowing that that can mimic these things. Other things you're thinking of here, Hans, before Gabby reveals the final diagnosis to us, or I should say, other thoughts on what this could be, and then what tests would you get to try to nail it down?
My guess would be, is it possible to check the serum for the most likely parasites and infectious diseases of the area. So fungi, bacteria, and maybe some parasites that would be most likely. So some immunoserology, something like this.
Yeah, excellent. Excellent. So yeah, blood cultures, right? Because if we find that the patient is bacteremic and we know the bug and its sensitivities and we treat that and this thing starts going away, then it's probably a bacterial abscess, not a tumor. Serologies can be tough, right? You might say, what if we have positive serology for neurocysticercosis? Probably many patients in an endemic region will have the positive test, and it doesn't mean the brain stuff is related, right? So as far as endemic fungi, does anyone know for Brazil, one fungus probably none of us have seen, but Gabby has probably seen a lot of? I'm watching the series of Valeria and Hans's facial expressions trying to think of it. I think it's a fungus, right? Paracocxioides. I haven't seen a case, but is it a fungus?
Yes, it's very common here in Peru as well. I haven't seen a case of paracoxy presenting like a mass on the brain, actually. But I mean, I would love to learn from Gabby, from her experience.
Yeah. So would the serology help us? Again, Gabby can teach us how to use that serology there in an endemic area. The question would always be, what percent of the population just have the exposure, right? Many of us probably have positive JC virus, toxoplasmosis, right? As long as we're not immunosuppressed, it's not going to matter to us. Honestly, most of these cases where you have a ring enhancing lesion there and you do a lot of serologies and blood work and you don't find it, patients need some type of biopsy. People might say biopsying the brain, but this is very close to the cortical surface. It can be a stereotactic needle biopsy, and then you know, right? Is this malignant or infectious? And if it's infectious, what is it? I saw a case recently where it was multiple ring enhancing lesions in an immunosuppressed patient, I think multiple myeloma, and they got scans and they got lumbar punctures and they consulted neurology. And I said, you're going to need a piece of that. Like, there's no way we're going to figure out what it is. You can get, if the blood cultures don't tell you, there's no vegetation on the echo to tell you. And people just kept putting antibiotics, and neurology kept saying, you need to biopsy. And they said, but she's stable. And the neurosurgeons didn't want to biopsy. She's sick. Finally, they biopsied. It was nocardia. No way anyone was going to diagnose that, right, without putting a needle in it. And for weeks, this woman was not getting the treatment. I'm not criticizing anyone, just saying this happens a lot. Do your first pass, but most of these patients are going to need to have a needle in there and aspirate it to know what it is, or find out that, hey, it's a tumor. And then we know if it needs to be converted to a resection in that case. So, gee, she's young and healthy, and could she have a brain tumor here? She sure could. Could she have a subacute chronic infection? She sure could. There are ways you could try to get at this with nuclear imaging. You could get a PET or a SPECT, and if it's very hypermetabolic, maybe tell you it's a tumor, whereas an abscess might be less, but these can be hard to interpret and very hard to obtain. So probably, I'm going to guess, Gabby and her colleagues ultimately put a needle in there. And what did they find? I mean, I've never seen a case of paracocxioides, and I've always wanted to. Maybe Gabby is fulfilling my wish today, but I wouldn't have any clinical way of saying this is one thing versus another. And that's why tissue is the issue, as I would say. So did you figure it out in some more clever way, Gabby, or did you put a needle in it? And if so, what did you find?
No, actually, we had to do a brain biopsy to do the final diagnosis, as you told. So can I read the result of the brain? Okay. So the result was chronic granulomatous inflammation with caseous necrosis, and she had an acid fasting stain positive. Valeria is smiling because this is the first day that she doesn't mention this diagnosis in the first.
I think she mentioned it still, but yeah. Yeah, we had a series probably a year ago where Valeria presented several TB cases presenting in different ways in a row. And we thought, well, she's not going to present TB a second time. And so, right, in a TB endemic area, a ring enhancing lesion is TB until proven otherwise. Isn't that those of you who practice in those regions? When I've worked in those regions, sometimes the radiologist just write tuberculoma, and you say, but couldn't it be a tumor? And they say it could, but here It's almost always a tuberculoma. And again, had you done a PPD and had you done a chest X-ray, some patients have just isolated CNS TB. And had you done any of those tests and seen other evidence of TB, I guess you could have said if she had a clear focus on her chest X-ray or a very obvious PPD, although I think in Brazil, don't most people get the BCG vaccine, so the PPD can be hard to interpret. Maybe you could treat for TB and rescan the brain lesion and see if it goes down, but if you really had nothing elsewhere, probably your best bet is to just find out what it is, and then this patient would get 4-drug therapy, and steroids are controversial, but would probably get them. And so how did you treat Gabby, and how did the patient do?
Yeah, so she was started on rifampicin, ethambutol, pyrazinamide, and levofloxacin, but then she developed hepatotoxicity, and then she changed. We changed the medication regime to rifampicin, ethambutol, levofloxacin, and streptomycin. She was also treated with prednisone. And the treatment, it was for doing 10 months. She had a chest X-ray. I don't have the PPD result here, but the chest X-ray was normal. And for the seizures, we started her on carbamazepine, and I think she had a CT scan like by the end of the treatment, and she didn't have any other seizures, and the lesion was gone. So she recovered really well.
Fantastic. Great. And did she, so another important teaching point, some people will say, oh, it can't be TB if the chest X-ray is normal. I don't know the number, but a significant percentage of people have extra pulmonary TB with nothing to show for it on the chest X-ray. And so the drug regimen for the TB sounds relatively straightforward. Most people will add steroids for the edema. And then of course, we forgot about the seizures, right? We got so obsessed with the ring enhancing lesion, we have to treat those too. And the challenge is picking a medicine that's not going to interact too much with the TB drugs, which all have all kinds of drug-drug interactions. Amazing case, Gabby. Brilliant discussion, Hans and Valeria, first on how to identify a seizure, and then how to think about the differential diagnosis for a seizure, and how to work up a seizure. And ultimately, we knew from the beginning we'd need a scan, and then how to think about a ring enhancing lesion. And the important point that a lot of these are going to need a needle in them if you don't find anything systemically. And people will, in my experience, chase their tails for weeks just adding antibiotics and scanning and not making progress. Especially a lesion this close to the cortical surface. That sounds scary, but very easy, low morbidity thing for a neurosurgeon to do. Amazing. Well, thank you all. What a great case. Hope those of you who are still here see how fun this is for next time. And then I know Maria was scribing teaching points and had to leave. I don't know if Gabby or someone wants to read them, or we'll just post them since we're over time. Maybe we'll just post them since we're over time. Fantastic. Wonderful. Thank you all again, the three of you. And then thanks to the rest of you for joining us. Please consider bringing a case or discussing in 3 weeks from today, the last week of February, I think, when I will be back. Take care. Thank you, everyone.